We shall now go on to our next speaker, Dr. Anil Mandal, a very famous personality and who is a senior consultant in the Child Eye Care Center at LVPI Hyderabad, and he's going to take a difficult topic, aniridia. On to you, Doctor.
So, thank you for the opportunity. I take this liberty to present a management strategy for glaucoma in aniridia rather than presenting a single case. Aniridia is a very difficult type of glaucoma with developmental basis. PAX6 mutation is the most common mutation, and the associated features are cataract, glaucoma, keratopathy, and optic nerve or macular hypoplasia. This is a typical picture of aniridia. The term aniridia is a misnomer. Each and every patient of aniridia will have a short iris stump. This patient we managed by primary combined trabeculotomy, trabeculectomy. I'll come to the presentation later on. You can see the gonio anomaly here. Even though aniridia, you can see the short iris stump as you can see in this clinic here. And that's the reason management should be done and the iris stump should be managed in trabeculectomy surgery. I'm presenting few important slides to depict peculiar anatomical changes. Here is a patient who has aniridia with cataract and a very rare finding of circular pigmentary line behind the lens, which is classically seen in pigmentary glaucoma named as Gentmeyer's line. Under the two illuminations showing the same picture here. In my 30 years of practice, I have seen this kind of picture in 2 patients with congenital aniridia. A very advanced stage of the disease giving rise to dry eye along with limbal stem cell deficiency. The other eye of the same patient, aniridia associated keratopathy and fundus two illumination showing extensive vascularization of the cornea. Here is a patient who presented to us for management of aniridic glaucoma, and the patient had history of nephrectomy. It's a case of Wilms tumor and aniridia. The mechanism of glaucoma in the early stage can be related to angle dysgenesis, as we see in primary glaucoma in children. But in late onset disease, it is the peripheral iris stump giving rise to peripheral anterior synechia formation, jeoparding of the angle. Here is a patient who presented to us with congenital onset developmental glaucoma associated with aniridia. You can see the lens margin, you can see the ciliary process. This is the kind of situation we prefer to perform primary combined trabeculotomy and trabeculectomy. We published recently a paper where 18 years of collection patients of early onset glaucoma who underwent combined trabeculotomy, trabeculectomy. By early onset, we mean patients who were operated within 3 years of age. You know, primary surgical technique was combined trabeculotomy, trabeculectomy without any antimetabolite, and data was collected on retrospective chart review. 2 surgeons were involved in the surgical technique. In some cases, Slem's canal was not identified, and that's the reason only trabeculectomy was done. We do not believe in using intraoperative mitomycin C in primary surgery in congenital glaucoma, and here is a series where all the patients were done without any antifibrotic therapy at primary surgery. The outcome measures were defined before the data analysis. Complete success was defined intraocular pressure 5 to 21 millimeter of mercury with no medication, and when medications was used to control the intraocular pressure, it was in the category of qualified success. Statistical analysis was done. 76 eyes of 42 children were initially identified, of which 35 children were included, giving rise to 66 eyes where combined trabeculotomy was done. This is the demographic data. I'm not going into the details of the paper. Here is the percentage of eyes in a line graph diagram showing intraocular pressure more than 21 millimeter of mercury over different time limits. The success rate was defined with cutoff value of 21 millimeter of mercury, and in another definition, we took cutoff value as 16 millimeter of mercury. Again, when we took 16 millimeter of mercury, intraocular pressure control was achieved without any medication, and at the end of 1 year, success rate was approximately 81%, decreased to 68% at the end of 6 years, and by the 10th year, success rate was 63%. In patients where primary surgery failed, these are the patients which were not included in the primary analysis. These were after trabeculotomy, additional surgery performed. Glaucoma drainage implant, Adi implant was done in one, Ahmed glaucoma valve in one eye, repeat trabeculectomy with mitomycin in 2 eyes, and transscleral cytophotocoagulation was done in 3 eyes. Here is a patient. We did combined trabeculectomy in the right eye, and left eye intraocular pressure was controlled with one medication, and there was no corneal edema. We are following this child. This child was having macular hypoplasia. The bleb appearance of this child photographed at 6 months postoperative. Here is a patient we initially operated for trabeculectomy with mitomycin C in the year 1995. The child was doing all right till 10 years. After that, cataract developed. Cataract surgery was performed sequentially in right eye, then the left eye. Elsewhere, we used to see this child on regular follow-up. When the cataract developed, cataract surgery was done elsewhere and was doing well, but later on developed corneal bleb infection and endophthalmitis, which was managed elsewhere. And when we saw the child was having no perception of light.
1 minute remaining, sir.
Right eye. And left eye was having good vision, 20/60 without any anti-glaucoma medication. Here is the patient. The right eye ultimately underwent evisceration with implant, and later on fitting of artificial eye, that is prosthetic eye. We have had the experience of following this child for about 28 years. So this is the management strategy. The study limitation so far, primary combined trabeculectomy was done, is written here. And in anaeritic cases, I feel as a primary option in congenital onset or early onset within 3 years, combined trabeculectomy can be the first option of management. Thank you.
Thank you very much. Wanted to just ask you one question before we go to the next speaker. Is there a role of doing a prophylactic goniotomy in this condition?
Yes, can I answer that?
Yes, doctor.
Prophylactic goniotomy, the advocate is Dr. David Walton. Now, he published a large series in Archives of Ophthalmology in the year 2004. Some of his associates believe in that, but prophylactic goniotomy, where at presentation cornea is clear and there is no glaucoma, there is no optic disc change, no evidence of glaucoma, I mean, but by total evaluation, very few surgeons will be advocating that. I have consulted and in fact visited Dr. David Walton for twice for a series for about 1 week each time. I have seen some patients he used to do prophylactic goniotomy, but I don't think any expert is doing that kind of approach.
But I think in a sporadic aniridia, doing a Wilms tumor screening makes sense, I suppose.
Yes, it is very important from the medico-legal point of view also. If we do not really advise proper evaluation, ultrasound abdomen to rule out renal tumor, later on if it is detected, and in fact it's not a one-time job, periodic checkup according to the requirement, it should be done. Otherwise, it falls into the category of medico-legal issues in the future.
Thank you so much for your contribution, Doctor. Thank you.